I will try to tell you a case where we applied isolated calcaneocuboid fusion. The patient was 20 years old, and he presented with a pain in the lateral column of his left foot. He had a history of ankle sprain 2 years ago, but at initial phase, it was not really painful, but the pain increased gradually since that day and started to interfere with his daily activities. According to what he really defined, pain usually starts after a few hours of activity and prevents him from performing his daily tasks, and also causes limping when it's painful. On the physical examination, the lateral column was tender. The pain was centralized on the calcaneocuboid joint, and the range of motions were normal, and no sign of instability or impingement was detected. So these were X-rays of the patient. The direct radiography showed degeneration in the calcaneocuboid joint. And we ordered an MRI, and an osteochondral lesion of cuboid involving more than half of the joint was detected, as we can see in 3 sections. And we planned a conservative treatment for the patient, but 6 months of conservative treatment didn't provide any improvement in pain. And the surgical options were discussed with the patient, and fusion of the calcaneocuboid joint was recommended since the osteochondral lesion was large, involving more than half of the joint surface, and there was an evident degeneration, especially on the cuboid side in the X-ray. So we proceeded with the calcaneocuboid joint fusion. A skin incision was made over the calcaneocuboid joint. And at this slide, I will try to give you what we have done with a step-by-step video. We started with the debridement of the cartilage with a rongeur after making some room for us. We also applied curettage of the chondral parts, and then we tried to reach the medial side as the medial chondral structures can be left, and that's why we placed a laminar sprayer to see the medial side better. And after debriding the medial side, we have to make sure that the medial side is debrided, and we can check if the gap is closing to see if the medial side is clearly observed. After we washed out the joint, we checked if the gap is closing. So we made sure that the medial side was completely debrided. And then we measured the joint length to have a iliac graft, since we thought that the lateral column will be shortened due to the large osteochondral lesion debridement. And we harvested the graft with the oscillating saw. And then we completed the cut. We also completed the cuts with an osteotome. And then we harvested the cortical iliac autograft, and also we had some kind of cancellous iliac autograft to use. And we turned back to calcaneocuboid joint, and we tried the graft. It was bulky. It would cause a lengthening of the lateral column, so we trimmed down it and downsized it to make it a better one. And before placing the grafts, we drilled the joint surfaces to promote healing, to have intramedullary content into the joint. And we filled the medial with some kind of cancellous grafts. And then we placed our cortical autograft to restore a lateral column and provide structural support. And then we applied the arthrodesis with a plate. Compression was applied through a mini plate, which was then secured with locked screws. And the post-op rehabilitation included a short leg cast for 3 weeks, and we didn't want him to bear weight for 3 weeks. After that, the range of motion exercises were started, and partial weight bearing with a walking boot were started in the 4th week, and full weight bearing was allowed 6 weeks after surgery. Full consolidation was achieved at the 4th month, and post-operative functional score increased significantly compared to pre-operative period. And post-operative 1-year X-rays are available in the slide, as we can see the full consolidation. So the osteochondral lesions of the cuboid are rarely described in the literature, so the conservative treatment can fail, so surgery should also be considered. And surgical options can include both salvage procedures, maybe microfracture and some allografts, but fusion should be also considered when the degeneration of joint space exists and calcaneocuboid joint involvement is more than half of the joint. So we know that isolated arthrodesis of mid-tarsal joints can alter the biomechanics of the foot and may lead to arthrosis in other joints, but a calcaneal joint has the least mobility, and its fusion almost has no significant influence on remaining high foot motion, so we can be more safe about that. And isolated calcaneocuboid joint debridement can lead to shortening in the lateral column if the osteochondral lesion is large. So the shortening should be avoided by placement of a bone graft in such cases. Thank you for listening.